Hello everyone and welcome to my YouTube channel. This is Dr. Naz and today I'll be discussing about malaria. It is caused by a protozoa called plasmodium and it is transmitted by the bite of a female anopheline mosquito. Plasmodium has 5 species: Plasmodium falciparum, vivax, ovale, malaria and knowlesi. Plasmodium falciparum invade red blood cell of all ages, especially young cells, and its incubation period is 8 to 25 days. Vivax and ovale invade reticulocytes and they have the similar incubation period. However, Plasmodium malariae invade normoblast cells and its incubation period is 15 to 30 days. So, I'll start the life cycle from the mosquito host phase. And when a female mosquito take up gametocytes from an infected person's blood, these gametocytes are fertilized and development take place in the mosquito's intestine. From the intestine, mature infective sporozoites migrate to the mosquito's salivary gland, and when the mosquito bite another human, these sporozoites are injected into the human with that mosquito bite. So sporozoites which are not destroyed by the immune system are taken up by the liver. In the liver they are multiplied as merozoites. When infected hepatocytes rupture, these merozoites are released into the blood and taken up by the erythrocytes, and in erythrocytes they further multiply. So in the cases of Plasmodium vivax and Plasmodium ovale, a few parasites remain dormant in the liver as hypnozoites, which when reactivated causing relapsing infection. Now the cycle in erythrocyte. Inside the red blood cells, the parasite again multiply, forming new merozoites. When erythrocytes rupture, merozoites are released and they infect further red blood cells. Each cycle of this takes place 48 hours in Plasmodium falciparum, vivax and ovale, however 72 hours in Plasmodium malariae. So clinical features of Plasmodium falciparum: it is the most dangerous Plasmodium species and it is characterized by high-grade fever accompanied by rigors and chills and drenching sweats. Fever has no pattern. It may be associated with malaise, headache, vomiting, body ache, jaundice and hepatosplenomegaly. Jaundice and hepatosplenomegaly especially occurs during the phase in which they are multiplying inside the liver, and jaundice occur when the liver cells rupture. Anemia and thrombocytopenia. Why anemia will occur? When they are multiplying in the red blood cell and they rupture that red blood cell, so it will lead to anemia. Severe Plasmodium falciparum is associated with high parasitemia, that is more than 2% of red cells are infected in the blood. It may present with cerebral malaria, which is the most common presentation of severe falciparum infection. Diminished consciousness, confusion and convulsions are the feature of cerebral malaria. It may progress to coma and death. It is the most common cause of death in adults with malaria. Black water fever refers to the passage of dark urine because of hemoglobinuria. It is due to widespread intravascular hemolysis affecting both parasitized and non-parasitized red blood cells. Other complications of falciparum include severe anemia, which may be due to dysregulation of erythropoiesis, splenomegaly, depletion of folate stores and intravascular hemolysis. Plasmodium falciparum can bind to placental protein, chondroitin sulfate, and may lead to abortion and IUGR in pregnant women. Other complications can include disseminated intravascular coagulation, acute respiratory distress syndrome, hypoglycemia, metabolic acidosis in gastrointestinal tract, diarrhea, jaundice, and splenic rupture may occur. In Plasmodium falciparum, trophozoites containing red blood cells adhere to vascular endothelium of venules in brain, kidney, liver and lungs, also in GIT by forming NOP proteins. They also form rosette and Rolex with unaffected RBCs. Due to these, the vessels become congested and they lead to organ damage and rupture, which results in release of schizons and toxin into the blood. That's why different organ systems are involved in malaria, especially falciparum malaria. The falciparum malaria does not affect people with sickle cell anemia, G6PD deficiency, thalassemia and HLA positive individuals. Now come to the clinical features of Plasmodium vivax and ovale. They both are referred to as benign tertian malaria because fever spikes every 48 hours. Anemia may develop slowly with tender hepatosplenomegaly. They have a chronic carrier state which is known as hypnozoids, and they are present in liver and can cause relapses for many years after the infection. Plasmodium malaria is known as quartan fever because the fever occurs after every 72 hours. It is associated with glomerulonephritis and nephrotic syndrome. So the diagnosis of malaria is made from thick and thin blood films by Jim Sustain. Thick film shows all blood stages of parasites because RBCs are lysed in this stage. And thin film is essential to confirm the diagnosis, to identify the species of parasite, and to quantify parasitic load in Plasmodium falciparum infection. How can we quantify the load? By counting percentage of affected erythrocytes. In Plasmodium falciparum, only ring stage is seen in initial stages. Another test is rapid stick test. It is extremely sensitive and specific for Plasmodium falciparum. Immunochromatography test for malarial antigens such as Optimal that detects Plasmodium lactate dehydrogenase enzyme of several species. Also Parasite-F that detects Plasmodium falciparum histidine-rich protein 2. Other tests may include PCR, DNA detection. It detects recurrence of same parasite or reinfection with other parasite. Almost all cases of Plasmodium are resistant to chloroquine and sulfadoxine pyrimethamine, that is Fansidar. So artemisinin based treatment is recommended, and these can be followed into two regimes. So the first regime is treatment of choice, and it includes co-artemether, which is the combination of artemether and lumefantrine. These tablets are given for 3 days at 0 hour, 8 hour, then 24th hour, then 36th hour of infection, 48, and then 60 hour. Regime 2 include quinine plus doxycycline or with clindamycin or with Malaron, which is the combination of atovaquone and proguanil. So these are given as shown. However, doxycycline is contraindicated in pregnancy. So complicated Plasmodium falciparum is treated with IV artesunate 2.4 mg per kg at 0 hour, then 12th hour, and then 24th hour. And then it is given once daily for 7 days. However, once the patient is stable enough to take orally, we will switch to oral artesunate. Another drug which can be given is quinine salt. The loading dose is 20 mg per kg infused over 4 hours. Then it is followed by maintenance dose of 10 mg per kg infused over 4 hours. And it is done every 8 hourly. The loading dose should not be given if the patient has received quinine, quinidine or mefloquine during the previous 24 hours. And during the treatment, ECG monitoring should be done, and a special consideration should be taken on QRS complex and QT interval. The drug of choice for Plasmodium vivax ovale and malaria is chloroquine, and these all species are always susceptible to this drug. The treatment regime consists of chloroquine 600 mg start dose, then 300 mg 6 hours later, same dose 24 hours later, and then 300 mg further 24 hours later. Plasmodium vivax and ovale are associated with relapses due to the presence of hypnozoites in the liver. Therefore, infection with these agents require the course of primaquine. Primaquine destroys hypnozoite phase in the liver. So to protect ourselves from insect bite, insecticide treated bed nets should be used. Diethyl metatolamide containing insect repellents should be used. Person should cover up their extremities with clothes when going out after the dark. Sleeping under permethrin impregnated nets can be considered, and using insecticide sprays. Chemoprophylaxis of malaria should be taken before traveling to endemic areas. In low chloroquine resistant areas, chloroquine and proguanil should be taken, and it should be started 1 week before and continued until 4 weeks after the travel. In high chloroquine resistant areas, any of these drugs, mefloquine, doxycycline or Malaron, can be taken. The doses are written in the chart, and mefloquine should be started 2 to 3 weeks before and continued until 4 weeks after the travel. Doxycycline should be started 1 week before and continued until 4 weeks after the travel. However, Malaron should be started 1 to 2 days before and continued until 1 week after return. I hope you learned something from the video. If you do, then like the video and subscribe to my YouTube channel so that I get motivation to make further videos. Thank you for watching.